The quality measure I chose was smoking in the United States. According to our book, it's under adults who smoke. Cigarette smoking has long been found to cause serious harms, including target organ damage, lung and other cancers, and death. Although cigarette consumption has been declining since the mid-1960s due to increased education, campaigns, and research, cigarettes remain by far the most commonly used tobacco product in the United States. From 2005 to 2011, the most marked decline was seen in those 18 to 24 years of age, from 25% to 19%. One improvement made in smoking cessation was noted in a randomized clinical trial at General Electric. A bundle of incentives worth $750 for smoking cessation nearly tripled quit rates from 5% to 15% and led to a program adapted by General Electric for its U.S. employees. Now, many companies have adopted either a non-smoking incentive or a smoker charge. The National Lung Screening Trial is also an area that we have improved on. It's started in 2002. The National Lung Screening Trial compared two ways of detecting lung cancer with a low-dose CT or a chest X-ray. This is why I chose this particular issue, because this is one of the roles that I work in as a nurse practitioner, doing low-dose CTs and smoking cessation. There have been studies that show that nicotine is as addictive as heroin, cocaine, or alcohol. Because of that, attempts to quit are often unsuccessful because of withdrawal, stress, and weight gain. This is especially true in younger people, and issues like substance abuse, psychological issues, and family circumstances also weigh in on issues of quitting smoking. It may be also that some smokers may be discouraged to hear how difficult it can be to quit. Primary care assistance in smoking cessation can help. Unfortunately, only approximately half of smokers reported being assisted during post-screening follow-up primary care visits. However, I know from personal experience doing smoking cessation, it is difficult because in my program we can only see them for one visit, and this is based on CMS reimbursement guidelines. The e-cigarette was supposed to be a great breakthrough to get people to quit the cigarettes and all the harmful toxins that go along with them. However, we don't know how safe they are, and we're not sure if they're really better. The use of electronic cigarettes has nearly doubled, though, among all adults during 2010 to 2011, from 3% to 6%. So this is an area that we're not quite sure how this is going to impact the tobacco industry and the harmful or long-lasting effects of using e-cigarettes. Health professionals and health systems are incentivized by reimbursement. Reimbursement is a huge driver of clinical services and delivery. This is the CMS guidelines. CMS is the Center for Medicaid and Medicare Services. The Affordable Care Act partially shifted provider reimbursement from quantity of care towards quality and meaningful use. Meaningful use, which is exchanging information between providers, insurers, and patients. CMS awards incentive payments to eligible providers and eligible hospitals that demonstrate meaningful use. This is the meaningful use for tobacco. It's one of the quality measures, and assesses the percentage of adult patient screens for tobacco use and those identified as a tobacco user. The Joint Commission developed the Tobacco Performance Measure Set, which are 3 standardized performance measures addressing tobacco screening and cessation counseling as well. One example of public policy affecting smoking is public place smoking bans. There's evidence that countries and their populations benefit from improved health after introducing smoking bans, importantly to do with heart and blood vessels. We need research on the continued long-term impact of smoking bans on the health outcome of specific groups, however, such as young children, disadvantaged, and minority groups. New York State has one of the highest state cigarette taxes in the United States. Enacted in 1989 and then amended in 2017, the Clean Indoor Air Act prohibits the smoking of tobacco within nearly all indoor and certain public outdoor spaces. There's other laws in New York State. I've chosen to highlight a few. Smoking and vaping is prohibited on hospital and residential health care facility grounds, and smoking and vaping is prohibited on playgrounds in New York State. More specifically, at a local level, the Erie County Legislative voted to approve the Public Health Protection Act of 2018, which makes it illegal to smoke in a motor vehicle with a child under 18. Federal public policy has shown to decrease unfavorable outcomes specifically for vulnerable populations, including children and pregnant women, by way of reducing secondhand smoke exposure. As well as SFA, which is smoke-free air laws in bars with some exemptions, significantly reduce the probability of smoking inhalation. Local laws seem to have to be improvements, such as previously discussed smoking in cars with children, the ban that they have in Erie County, New York. However, I think personally federal guidelines would make it less confusing when and where people can smoke, and it would also create a much larger cohort to study in order to prove such measures are effective. If I were to go to the Congressional Committee, I would ask for more funding for research into the impact of smoke-free areas and the impact on smoking cessation rates and overall public health outcomes. I'd ask for increased areas of smoke-free policy, including perhaps in cars with children, smoke in homes with children or pregnant women, and restaurants, bars, etc. Also, government grants for implementing cash for smoking cessation or non-smoker incentive bonuses for more companies, as it was shown to be effective at General Electric. Here's my references. Thanks for listening.